In this video, I'm gonna talk about Plateau iris syndrome. Talk about means I'm gonna read Shields textbook of glaucoma 6th edition. I'm gonna read that part about Plateau iris. Then I have also added my favorite videos on Plateau iris. You can go through them. So it will help you to understand Plateau iris in a better way, and you will also remember it for a longer time if you go through all the videos, multiple videos. It's like a revision, so you'll remember it for a longer time if you see so many videos. Actually you should see actually you should read the topic now, then see the videos, then after a week again read it, after a month again read the same thing. Then it will help in building a long-term memory about that topic or about that particular thing. So it's about consistency and sincerity and mainly interest in that topic. So Plateau iris, one mechanism leading to angle closure glaucoma appears to result from an abnormal anatomic configuration of the antechamber angle without pupillary block. It is far less common than pupillary block glaucoma and is usually only recognized after a peripheral iridotomy for a presumed pupillary block mechanism has failed. Consequently, two variations of Plateau iris have been described. Plateau iris configuration. This diagnosis is made preoperatively on the basis of the gonioscopic findings of a closed antechamber angle but a flat iris plane, as opposed to the forward moving of peripheral iris with the pupillary block mechanism, and a more normal central antechamber depth. Relative pupillary block plays a significant role in this situation, and most of these cases are cured by peripheral iridotomy. Recently, Plateau iris configuration with an angle that is oppositionally closed after iridotomy was described in association with long anterior zonules. Now, Plateau iris syndrome. Plateau iris syndrome constitutes a small percentage of eyes with the Plateau iris configuration and represents the true Plateau iris mechanism. The peripheral iris is anteriorly displaced so that as the pupil is dilated, it bunches up and closes the antechamber angle despite a patent iridotomy. So Plateau iris syndrome means iris configuration, Plateau iris configuration along with the patent iridotomy. This was traditionally believed to be caused at least partly by an anterior insertion of the iris, although studies with ultrasonographic biomicroscopy suggest that an anterior position of the ciliary processes prevents the peripheral iris from falling posteriorly after an iridotomy. Progressive anterior dislocation of the ciliary body with bolstering of the peripheral iris, bolstering I think it means bunching up of the peripheral iris, and formation of peripheral anterior synecdoche, that is chronic angle closure, has been described in case of Plateau iris with long-term follow-up with use of ultrasonographic biomicroscopy. Clinically, it is important to suspect this syndrome if the peripheral anterior chamber is shallow, that is Van Herrick technique less than one-fourth of the corneal thickness, despite a patent peripheral iridotomy, or if there is a high Plateau iris configuration on gonioscopy or an attack of angle closure glaucoma despite a patent peripheral iridotomy. Additional tests that may help confirm the diagnosis include ultrasonographic biomicroscopy and provoking angle closure with phenylephrine 2.5% or 5%, ensuring that the pupil dilates to more than 7 mm and that the IOP increases after dilation. These cases are usually treated with dilute pilocarpine at bedtime or with peripheral iridoplasty. See chapter 12. Pseudoplateau iris due to cysts of the iris or ciliary body. Since the advent of ultrasonographic biomicroscopy, it has become evident that cysts of the iris or ciliary body epithelium can mimic the Plateau iris syndrome. Clinically, this condition can be termed pseudo-Plateau iris and may be difficult to distinguish from true Plateau iris. In a review of patients with Plateau and pseudo-Plateau iris with diagnosis based on results of ultrasound biomicroscopic examination, patients with pseudo-Plateau iris had a greater degree of tubercular measure pigmentation, had fewer clock hours of gonioscopic angle closure, and were more likely to be male and have bumpy peripheral iris appearance, visualized by using a narrow slit beam, compared with patients who had Plateau iris. Spherical equivalent did not differ significantly between the two groups. It is important to confirm the diagnosis and the extent of cysts by performing ultrasound biomicroscopic examination because secondary cysts can result from traumatic implantation of epithelium, from metastatic or parasitic lesions, or after the long-term use of myotics. If significant angle closure is not present, the prognosis is generally good. In the case of significant angle closure, treatment may necessitate puncture of the cysts with a needle or with an ND-YAG laser. Aritoplasty can also be useful. Now figures. Figure 17.9. A. Schematic showing height of plateau and relationship to angle structures. When the height of the plateau is such that dilation of the pupil will result in occlusion of the tubercular meshwork, C and D, then angle closure is possible despite a patent peripheral iridotomy. B. Ultrasonographic microscopy shows plateau iris with the ciliary body touching the posterior iris. Figure 17.10 A. Slit lamp examination shows a bump on the peripheral iris. B. Ultrasonographic biomicroscopy reveals a large cyst in the iridociliary circles, creating a bump in the peripheral iris. C. Ultrasonographic biomicroscopy reveals multiple cysts within the iridociliary circles, creating a plateau-like configuration of the iris. Swelling of the ciliary body. Any disorder giving rise to the swelling of the ciliary body or forward rotation of the ciliary body can create a plateau-like configuration of the iris. Sulfur-based compounds may cause an idiosyncratic transient myopia, presumably produced by lens swelling and forward movement of the lens iris diaphragm. The conditions which cause the forward movement of the lens iris diaphragm associated with choroidal detachments and ciliary body swelling. Use of oral hydrochlorothiazide, oral acetazolamide, and topiramate, a new sulfur-derived anti-epileptic medication, have all been reported to precipitate bilateral angle closure glaucoma, presumably by this mechanism. Supraciliary effusions and ciliary body thickening also appear to be common after scleral buckling procedures. They can produce conditions conducive to angle closure through a combination of direct anterior iris rotation and induced pupillary block. Other conditions associated with ciliary body swelling include aqueous misdirection, acquired immunodeficiency syndrome (AIDS), and other inflammatory disorders, and idiopathic uveal effusion syndrome. Now, key points. Plateau iris is a form of angle closure glaucoma in which an anterior position of the ciliary processes appears to be responsible for the angle closure. Pseudo-plateau iris is a condition in which primary cysts in the iridociliary circles result in plateau iris-like configuration with subsequent angle closure glaucoma. Swelling of the ciliary body with angle closure can occur by various mechanisms, including use of sulfur-based oral medications and scleral buckling. Now I'm going to read the discussion part that is given on the site www.gonioscopy.org, in which a case on plateau iris is presented. I'm going to read only discussion part and also some treatment and differential diagnosis part. So discussion. Plateau-Iris syndrome is a relatively uncommon form of primary angle closure glaucoma that is seen more often in younger adults than pupillary block angle closure glaucoma. It is caused by large or anteriorly positioned ciliary processes that push the peripheral iris forward. The mechanical position of the ciliary processes against the trabecular meshwork crowds the angle and obstructs aqueous outflow. A component of pupillary block is often present. The central anterior chamber may appear to be of normal depth on slit lamp examination. On examination with gonioscopy, the iridocorneal angle is usually crowded or even closed. The iris typically appears to have flat approach on a plane to intersect Schwalbe's line with a steep drop off just before the trabecular meshwork. On indentation gonioscopy, the sine wave or double hump sign is seen. The peripheral hump is created by the iris draping over the ciliary body and the more central hump by the iris curving over the anterior lens surface. Ancillary imaging modalities can be helpful in making the diagnosis of plateau iris. Ultrasound biomicroscopy can provide information of the anterior segment anatomy as well as help confirm any element of pupillary block. Anterior segment optical coherence tomography (OCT) can also provide insight into the anatomy, but it is not a dynamic examination and does not provide as much information as gonioscopy. Treatment. Some element of pupillary block frequently exists in patients with plateau iris configuration, and generally peripheral laser iridotomy should be performed as the first intervention in patients suspected of having plateau iris. This oftentimes is an adequate treatment for eyes with plateau iris configuration. However, a subset of patients will have a persistent occludable angle despite a patent iridotomy causing plateau iris syndrome. Means first thing, try peripheral iridotomy and then iridoplasty. Eyes where the iridocorneal angle has persistent apposition or the intraocular pressure remains elevated should be treated with laser iridoplasty. The goal of laser iridoplasty is to place laser burns at the peripheral iris to shrink the iris and pull it from the angle. Of course, if laser surgical treatment is ineffective in controlling the intraocular pressure, conventional surgical procedures such as a trabeculectomy or a tube shunt may need to be implemented. Laser iridoplasty we have already seen, and laser argon iridoplasty we have already seen, and plateau iris is mentioned over there, so I decided to talk about plateau iris. Diagnosis: plateau iris syndrome. Differential diagnosis: pseudoplateau iris caused by iris cysts or ciliary body cysts, primary angle closure, pupillary block, peripheral anti-synecdoche. Epidemiological signs: exact incidence is not well known. Diagnosis should be suspected when angle closure occurs in patients who are young or myopic and when angle narrowing persists despite iridotomy. It generally occurs in younger age group versus primary pupillary block glaucoma, average age 30 and 50s. Slight female and hyperopic preponderance. Signs: narrowed or closed angle with iris on a plane to intersect with Schwalbe's line, then with a sharp drop off of the peripheral iris. Indentation gonioscopy reveals the double hump sign. Symptoms may present with angle closure either spontaneously or after pupillary dilation. More commonly, patients are asymptomatic and the diagnosis is made on routine examination. Treatment: often an element of pupillary block exists, so laser peripheral iridectomy is indicated. If not, improvement in appearance of the angle, laser iridoplasty to contract the peripheral, pulling the iris away from the crowded angle. Tomorrow I'm gonna talk about the same plateau iris. Means I'm gonna read the Jacobi, no, first Irving and then Jacobi, and after this video I'm gonna add multiple videos on plateau iris syndrome. Hope you like it, and I'm sure these videos and this reading will help you to remember Plateau iris syndrome for a longer time, as you will understand it and you will revise it through these multiple videos again and again. Thank you so much for listening to me patiently.
None of the producers have any financial interest in the products or procedures shown. Abnormal iris configuration and position can induce various clinical disorders. One among them is Plateau iris. Plateau iris is termed so as it simulates a plateau land, which is a land significantly raised above the surrounding region. Iris, imparting the unique color for the human eye, is named after the Greek goddess Eris, meaning rainbow. In the embryology of the eye, iris development starts as early as the 4th week of gestation. The iris develops from both layers of the optic cup. The outer layer of optic cup forms the pigmented layer of the iris, and the inner layer of the optic cup forms the non-pigmented layer of the iris. Neural crest cell gives rise to muscle layer of iris. PAX6 is the key gene in the eye development. Iris consists of an anterior limiting layer, stromal layer, anterior epithelial layer, and posterior pigmented epithelial layer. Anterior chamber angle is the anatomical recess formed between the corneosclera and the iris. Abnormal angle recess can lead to angle closure. The angle closure can be a block at iris level, block at ciliary body level, lens, or posterior segment. Plateau iris is a type of predisposition for angle closure where the block is at the level of the ciliary body. During development, if the ciliary body is positioned anteriorly, a large or anteriorly positioned ciliary body can maintain the iris root in proximity to the trabecular meshwork, creating a configuration of plateau iris. In this anatomical variation, the root of the iris is short and anteriorly inserted on the surface of the ciliary body. Plateau iris syndrome refers to the condition in which angle closure is still present, confirmed by gonioscopy, despite a patent peripheral iridotomy that has removed a degree of pupillary block and without a shallow anterior chamber. Though there are laser treatments for plateau iris, we present a novel method of single-pass 4-throw pupilloplasty for treatment of plateau iris. Ultrasound biomicroscopy and gonioscopy are the first-line tests for early assessment of plateau iris. With high-frequency, high-resolution ultrasound biomicroscopy, we can image the structures surrounding the ciliary body, posterior chamber, iris-lens relationship, and angle structures. The extent or the height to which the plateau rises determines whether or not the angle will close completely or only partially. In the complete plateau iris syndrome, the angle closes to the upper meshwork or Schwalbe's line, blocking aqueous outflow and leading to a rise in IOP. This situation is far less common than the incomplete syndrome, in which the angle closes only partially, leaving the upper portion of the filtering meshwork open so that the IOP will not rise. The physical presence of the lens behind the iris plane holds the iris in position and tries to prevent posterior movement of the central iris. As a result, a sinuous configuration occurs, termed as sigma sign. The iris follows the curvature of the lens, reaches its deepest point at the lens equator, then rises again over the ciliary processes before dropping peripherally, forming the double hump sign. Thus, much more force is needed during gonioscopy to open the angle than in the pupillary block because the ciliary processes must be displaced. Provocative testing in eyes with plateau iris configuration may help in diagnosis following laser iridotomy. Under normal room illumination, the angle with plateau configuration is narrow but open. During dark room provocation and ultrasound scanning, the peripheral iris dilates and appositional angle closure develops. Treatment options. An ND-YAG laser peripheral iridotomy can be performed in initial cases. An argon laser iridoplasty, where large spots are given for long duration and low power to extreme iris periphery, can also help in a few cases. In surgical methods, iridoplasty or pupilloplasty involves the mechanical pulling of the iris away from the angle and keeps the iris position using non-absorbable sutures and thereby maintains the angle open. In Plateau iris, we have shown satisfactory IOP control and good functional outcome with SFT. Single-pass fourth-row pupilloplasty is a novel method of pupilloplasty where single anterior chamber pass through the cornea followed by four throws are performed to make tight knot in the iris. This pulls the iris away from the angle and changes the vector. The technique provides easy learning curve with minimal tissue manipulation and surgical complications. The surgical knot is strong enough, comparable to a timber hitch knot, providing good stability. In an OCT analysis, we have noted no tissue damage or loss with maintenance of iris architecture. Knot region can show minimal changes with proline suture end far away from the corneal endothelium, thereby preventing endothelial cell loss. Postoperatively, pupil dilation can be performed to an extent to evaluate the fundus for screening. The post-surgical mydriasis has also been studied after SFT. Moreover, SFT can easily be combined with cataract surgery with intraocular lens implantation. Since there are a few treatment options and no treatment is fully successful, single-pass fourth-row pupilloplasty can certainly be useful in such eyes with failed PI. In this patient, the preoperative Plateau iris configuration, which has been corrected by SFT, can be seen by the anterior segment OCT analysis. Similarly, many patients with failed PI have been benefited with single-pass fourth-row pupilloplasty. Preoperative diagnosis of Plateau iris by gonioscopy and UBM is necessary in such cases. Trial of PI can be performed to rule out primary angle closure, simulating Plateau iris. Laser PI can fail in some patients due to peripheral anterior synechiae and scarring. SFT has a benefit of mechanical removal of the synechiae during surgery in such eyes. When PI seems to not provide control of IOP and the gonioscopic features shows Plateau iris, one can proceed with SFT. Thus, with added advantage of easy technique, less instrumentation, less surgical time, and good functional outcome, SFT in Plateau iris can be a good alternative.
This is Malika Hook from the University of Colorado with a new edition of One Slide in 5 Minutes. The topic is Plateau iris syndrome. Plateau iris syndrome is a form of angle closure, more common in younger female patients. These patients tend to be less hyperopic than those with classic primary angle closure. There's also often a family history of angle closure, and the inheritance pattern appears to be autosomal dominant with incomplete penetrance. The classic teaching is for the presence of anteriorly positioned ciliary processes, which push the peripheral iris forward, leading to angle closure. The anatomical findings in Plateau iris syndrome might be caused by a more anterior junction of the iris dilator muscle and ciliary epithelium, which may contribute to bunching of the iris and occlusion of the angle at the time of dilation. This is commonly described in textbooks as an anterior displacement of the iris insertion on the ciliary body. Some textbooks also split the findings into two different categories, with the first being Plateau iris configuration. This is an appositional or narrow angle confirmed by gonioscopy prior to LPI with a deep anterior chamber and flat iris, and Plateau iris syndrome, which is found after a patent iridotomy has been performed, eliminating the relative pupillary block, but with evidence of angle closure persisting in a deep central anterior chamber. On exam, the central anterior chamber is deep while the drainage angle is occluded. This is a distinguishing feature compared to primary angle closure. The classic examination question for trainees is the finding of a double hump sign on gonioscopy or ultrasound biomicroscopy. And I will point to the double hump sign here on the gonioscopic photo showing the double hump in the peripheral iris. You can also see anterior displacement of the ciliary processes, which is pushing the peripheral iris forward to occlude the anterior chamber and place the peripheral iris over the trabecular meshwork. Peripheral anterior synechiae often form in reverse from Schwalbe's line to the spur compared to classic pupillary block angle closure, where PAS form from posterior to anterior. Management includes laser peripheral iridotomy. However, angle closure is still possible despite a patent PI, and other steps such as cataract extraction and iridoplasty are often needed to further deepen the angle. We find that iridoplasty is really just a temporizing measure and have not utilized this in our clinics for the past decade. Our choice is to perform cataract extraction with endocyclophotocoagulation, which appears to be a more definitive treatment of the root cause of this disease process. Consider visiting keogt.com for more educational material, as well as the YouTube channel, which contains all of the 1-slide and 5-minute lectures. You can also get in touch with me on Twitter or Instagram. Thank you very much.
Recent evidence from the EAGLE study suggests that lens extraction alone may be sufficient for control of angle closure disease. However, angle closure exists in various forms, and phacoemulsification alone does not seem to resolve the pure Plateau mechanism of angle closure due to high ciliary body insertion. Plateau iris is apparent clinically as a relatively deep central anterior chamber, planar iris, and a double hump appearance on gonioscopy, despite the presence of a patent laser peripheral iridotomy. Anatomically, Plateau iris is defined as anteriorly positioned ciliary processes that push the peripheral iris forward, resulting in iridotrabecular proximity. Ultrasound biomicroscopic studies performed before and after lensectomy demonstrate that iridociliary apposition seems to persist in Plateau iris syndrome despite cataract extraction. Of late, endocycloplasty combined with phacoemulsification has been used to change the angle configuration. In endocycloplasty, diode laser energy is delivered endoscopically to the posterior aspect of the ciliary processes with the goal of shrinkage but not destruction. The surgical technique involves phacoemulsification and IOL surgery performed prior to endocycloplasty. We prefer a clear corneal incision for ease of access and its self-sealing properties. The same incision is typically used for both phacoemulsification and endocycloplasty. After phaco is completed and the IOL is in the bag, we fill up the anterior chamber with a cohesive viscosurgical device and introduce the endoscope in the AC to visualize the angle. Here, in this case, you can see the inferior 180 degrees. Except for 1 clock hour, the rest of the angle appears closed. We then mount the intraoperative ASOCT onto the microscope and take images. Following this, we inject cohesive ophthalmic viscosurgical device to expand the ciliary sulcus and create space for the endoscopic probe. The 20-gauge curved ECP probe, which consists of a fiber optic camera and a diode laser is placed through the main incision. We set the laser to continuous delivery mode with 250 to 500 milliwatts of power. We visualize the ciliary processes by passing the curved probe behind the iris and into the sulcus. A red aiming beam is aligned with the posterior aspect of the ciliary processes. It is important to start lasering at the posterior tail aspect of the ciliary processes and to observe the processes retreat posteriorly. The end point of laser treatment is marked by adequate shrinkage and whitening of the ciliary process. Care must be taken to avoid the application of too much energy, causing ciliary process to pop. Overtreatment may lead to excessive postoperative inflammation and a breakdown of the blood-aqueous barrier and its sequelae. It is possible to ablate approximately 30 to 40 processes through the phaco-incision. Once laser is completed, intraoperative ASOCT is repeated as seen here. Following this, the endoscope is reintroduced into the AC to visualize the angle yet again. Post-endocycloplasty, the scleral spur is now visible throughout the inferior 180 degrees. This is in stark contrast to the view after phaco and immediately prior to endocycloplasty. ASOCT has been done in several cases. All of them show increase in angle recess. Cycloablation pulls the entire ciliary process, including its anterior head, posteriorly. It thereby widens the anatomic angle and flattens the peripheral iris, along with photocoagulative effect of decrease in aqueous production. We conducted a pilot study of 10 eyes of 9 patients who were treated with combined phacoemulsification and endocycloplasty for angle closure disease. We have a median follow-up of 18 months now, and at this follow-up, median IOP decreased from 20 to 15.5 mm mercury, and the median number of anti-glaucoma medications decreased from 3 to 0. And logMAR visual acuity improved from 0.55 to 0. Currently, no treatment definitively addresses angle closure glaucoma secondary to Plateau iris syndrome. Our preliminary results suggest that endocycloplasty in combination with phacoemulsification and an IOL implantation directly impacts on this underlying morphological anomaly. Anterior segment OCT provides direct evidence of this.
We're going to talk about Plateau iris syndrome, a form of angle closure glaucoma that's caused by an abnormally anterior ciliary body. So you can see in the picture on the right, this ciliary body that's holding the iris up towards the trabecular meshwork. This often occurs in people younger than the usual pupillary block glaucoma patients. They are generally asymptomatic unless they develop an acute attack of angle closure. When we examine them, they have a fairly deep peripheral anterior chamber that one won't see the evidence of closure with the Van Herrick. So in the Van Herrick, we're bringing this light in where it first meets the clear cornea. You can see how the cornea tucks into the sclera here. And at that point, the chamber is fairly normally deep. But there's this very steep drop-off in the far periphery, as you can see here, that's characteristic of plateau iris. There is often an element of pupillary block involved, so a laser iridotomy should be performed. But then if the angle is still very narrow with this classic configuration, we should think about plateau iris. If the pressure is elevated, then instead of plateau iris configuration, we would call this plateau iris syndrome. The sign is looking on indentation gonioscopy and seeing this double hump or sine wave appearance. When one indents, the iris drapes over the ciliary body. So this is a sketch of the anterior chamber of a patient with plateau iris. We can see that the ciliary processes are very far forward. The peripheral chamber is fairly deep, and there's this sharp drop-off in the periphery. And then when we indent this eye, you can see the folds in the corneal endothelium. The iris drapes over the ciliary body and then over the lens, and we get this double hump appearance. It's very classic for plateau. And here we see a photograph. On the left, it's not indented. On the right, we're indenting. We can see this fullness in the far periphery here. A few video clips of indentation gonioscopy. You can see as we push in here, this roll in the far periphery, very classic for plateau iris. You can really imagine that the ciliary processes are back there holding the iris forward. Another example, steep drop-off in the far periphery. As I indent, we see this ridge in the far periphery right here. And again, you can, in your mind's eye, see that ciliary body holding the iris forward. As I release, the chamber is fairly deep, but you really don't get a great view of the trabecular meshwork because there's a steep drop-off in that far periphery. And one last video. I find that these video clips are the best way to get through the anatomy and the exam findings. So we can see the folds in the cornea. It should not be part of your normal exam, right? But I'm pushing here, and as I push, iris goes back and it drapes over that peripheral ciliary processes. You get this double hump sign. One hump here, one hump as it comes over the lens. Anterior segment OCT, you can see the slit here, deep chamber that just drops off in this slit in the periphery. And this is someone I just saw last week who has plateau iris ultrasound biomicroscopy. You just see this big forward ciliary body and just a little sliver of open angle just overlying that trabecular meshwork, right? There's a ciliary body, there's that sliver. The treatment, we do iridotomy, as I said before, to relieve the pupillary block. One can use cholinergic agonists like pilocarpine. Laser iridoplasty can be very effective in shrinking the iris out of the angle and perhaps even shrinking the ciliary body back some. It's important to do periodic gonioscopy. These angles can become narrow again later on after one does iridoplasty. So this is an angle closure due to an anterior ciliary body. One needs to remove the pupillary block with an iridotomy. You won't make this diagnosis on Van Herrick testing, so one does need to do gonioscopy. And indentation gonioscopy is really the key here. And we treat this with pilocarpine or iridoplasty. Just like to give a word of thanks to my daughter Sarah, who took some spectacular Lee Allen sketches of the anterior segment histopathology and turned them into these great drawings of indentation gonioscopy. So plateau iris is something you'll see in your practices. You need to learn to recognize it. You need to become good at gonioscopy. You need to become good at indentation or dynamic gonioscopy.
Great. So thank you so much, Sujandadi, for inviting me for being a part of this instruction course. And it's really an honor to be sharing the stage with Ramanjit Madam and Dr. Chandima also. So I'll just talk about gonoscopy, UBM, and ASOCT very briefly related to angle evaluation. Glaucoma, as we all know, Sujandali has already highlighted that in Indian perspective, we do have a higher prevalence of angle closure glaucoma, and angle closure glaucoma definitely has a higher prevalence of blindness compared to open angle glaucoma. And as she was really mentioning that this blindness in angle closure glaucoma actually is a preventable cause of blindness. If we do a timely gonoscopy, we detect closed angle, we do a iridotomy, most of these patients will never develop angle closure glaucoma. So this is one of type of blindness which can actually be prevented. But we are having so many webinars, so many meetings. Still, I believe most of patients in India are still treated without gonoscopy, and there are multiple reasons for it. One of the reason I believe is the reason that we still using this 2-mirror and 3-mirror gonoscope. And I tell you why. Previously, when I was trained in gonoscopy, I was using 2-mirror, 3-mirror. It takes more time. It's a little cumbersome and messy. And what happens, in a busy OPD, you tend to avoid doing gonoscopy. But when we switch to a 4-mirror gonoscope like a Sussman or a Poschner type, where you don't need any coupling gel, it's very quick, comfortable, and you end up doing much more gonoscopy, but it is more informative compared to a 2-mirror or a 3-mirror gonoscopy. Now, who needs gonoscopy? In Indian perspective, ideally, everyone needs a gonoscopy, but maybe practically it's not possible at this moment. At least we have to ensure that every glaucoma patient should have a gonoscopy done. Every patient with a family history of glaucoma, raised pressure, trauma, pigment dispersion, pseudoexfoliation, we should be doing a gonoscopy. There are certain clues which we can get during a system evaluation, for example, say glaucoma flecken or area of pupillary of atrophy, cucumber spindles, and pseudoexfoliation, which will give you an idea that this patient definitely needs a gonoscopic evaluation. The Van Herrick test is a good test for screening shallow chambers in a busy OPD, but it is not a replacement of gonoscopy. To do iridotomy, you should recheck by gonoscopy before you decide whether the patient needs an iridotomy or not. In gonoscopy, we all know that room should be slightly darkened to reduce meiosis-induced opening of the angle. Patient should be looking in the primary gauge. We should use low but adequate illumination. This is a small video which I have prepared to show that actually a gonoscopy and applanation doesn't take a lot of time. Like this particular patient, we have already used a paracane and fluorescent strip. Now we are doing an applanation tonometry in one eye. Then in the second eye, you can see the whole video is actually a 1-minute video. Once you have done the applanation tonometry, you are using a 4-mirror Poschner type of gonoscope. And we always instruct our OPD assistant to switch off the light. So you can see it's a darkened room. We have reduced the illumination. Since it's 4-mirror, you don't need to rotate. Just look up, down, right, left, and you can get an idea about the angle status. Similarly on the other eye also. So the whole process actually takes 1 minute. We should avoid putting too much of pressure because it leads to false opening of the angle. You can see these Descemet fold, which is indicating that we are probably putting too much pressure. Also, centration is very important. For example, in this case, you can see if you slightly decentered, the air may enter and can lead to problem in the visibility. So gonoscopy needs a bit of practice, and with practice, definitely all of us can master this technique. Another reason why we should switch to a 4-mirror gonoscope or an indentation gonoscope, because here you can differentiate an apposition and synechial closure. And as Suchandadi was mentioning in the last presentation, the recent definitions of angle closure disease, it is important to understand where you have synechial closure and where you have appositional closure. Because of that, you can classify the patients correctly. I won't go into detail of these structures, Coming to grading, I think there are a lot of grading schemes available, but what is important that you just write the structure it is visible in each quadrant before and after compression, and any other obvious abnormality which you can see. Quickly about some clinical example, you can see all the structures are visible here. So an open angle, this is a closed angle. You can see the corneal wedge is just meeting at the edge of the iris. None of the structures are visible, so it's a closed angle. It's another patient with closed angle where on compression the angle is opening up. This is a patient where the angle was closed. Post iridotomy, you can see these points Seneca. So it's a primary angle closure patient where the angle has partly opened up. In Plateau iris syndrome, even after iridotomy, sometimes the angle will not open up. You may need to compress. And these cases, often you see this typical double hump pattern or a sine wave sign, what indicates a Plateau iris configuration. Here comes the role of imaging also. UVM is a very good tool to confirm plateau iris because it can show these anteriorly positioned ciliary body. UVM is also good for cases like these. These type of humps are not very rare if you're doing a routine gonioscopy. Mostly they are because of iridociliary cyst, but sometimes it can be a tumor also lying behind it. Suppose you want to do a penetrating keratoplasty in a patient like this. In these cases, UVM can be very useful to assess the angle, also to see what is the extent of synechia, what is the lens status before you plan your surgery. Coming to ultrasound biomicroscopy, it is a high frequency ultrasound. It can be done in supine or sitting position. The biggest advantage of UVM is that it helps you to image that elusive iris diaphragm ciliary body complex. That is something previously we had no investigation where we can actually look at that ciliary body pars plana area. So it has got its own clinical application. For this is a normal scan. You can differentiate a closed and open angle. Here you can see the scleral spur is opening into the anterior chamber, so it's an open angle. In this another image, the scleral spur is covered by the iris, so it's a closed angle. It also helps you to understand the pathophysiology of glaucoma. For example, this is a closed angle. You can see on UBM also there is iridotrabecular contact. Once you've done a PI, the angles open up. So it gives you more idea about how the disease is working. It can also be used for quantification, but then that is mainly used for research purpose, not much useful for day-to-day clinical practice. There have been multiple studies comparing gonio with UBM or gonio with anterior segment OCT. Most of them have found to have good correlation, but both in UBM and anterior segment OCT, it has been seen that angle appear to be narrower compared to what we see in gonioscopy. But if we have a discrepancy, the gonioscopy will always be the gold standard when it comes to deciding whether the patient needs an iridotomy or not, or whether it's open angle or a closed angle. In pigmentary glaucoma, UBM is extremely useful to show the iridozonal contact. So these are the patients where you can consider going for a iridotomy. Unexplained hypertony, you can see the supraciliary effusion, which no other investigation can actually pinpoint that area of supraciliary effusion. Plus patients with cyclodialysis cleft, UBM definitely is better compared to gonioscopy in detecting these clefts. Also, post-surgical shallow chambers with malignant glaucoma, you can actually see this flattened and anterior rotated ciliary body, which is a diagnostic test for malignant glaucoma. So these are certain cases where UBM definitely gives you an extra information compared to a gonioscopy. Topiramate induced bilateral angular closure, UBM is diagnostic. You can see the supraciliary effusion, you can confirm it, plus post-treatment, how it is resolved, that can also be seen very nicely on a UBM. Coming to anti-segment OCT, anti-segment OCT uses 1310 nanometer wavelength. This is an optically based imaging system. So in this case, it has also evolved over years from a time domain, Visante OCT, to spectral domain, and now we have got the swept SOT OCT. In this case also, scleral spur is a very important landmark. When it opens into the anterior chamber, it's an open angle. If it is covered by the iris, this is regarded as the closed angle. Anti-segment OCT also gives you an idea about the anatomy of the angle, plus also helps you to understand the pathophysiology of glaucoma, for example, an open angle and closed angle. But if you can see here behind the iris, that is the ciliary body in pars plana area, cannot be imaged in a case of ASOCT because light cannot penetrate through pigmented iris epithelium. It's another patient pre and post iridotomy. You can see how the angles have opened up. Pigmentary glaucoma, you can see this concave iris pattern on an anti-segment OCT. In ASOCT also, you can quantify the structures and can see how the patients are changing over time. Again, that is more commonly used for research purposes and for studies. The certain advantages of ASOCT over gonioscopy in UBM: one, it's very, very rapid. you can do in sitting position, and it's a non-contact procedure, so extremely comfortable for the patient. But as I've already mentioned, you cannot image beyond the posterior pigmented epithelium of iris, so a malignant glaucoma or a plateau iris syndrome or even a zonal assessment cannot be done with the ASOCT. Quick comparison between UBM and ASOCT. UBM is ultrasound compared to optical, which is anti-segment OCT. UBM is contact compared to ASOCT, which is a non-contact procedure. UBM needs training. It's not easy. Sometimes you can injure the cornea. You need to practice. Compared to anti-segment OCT, is far more easier, less demanding compared to UBM. So to conclude, I'll say there are multiple investigations, ASOCT, CMFEP imaging, UBM, but most of the recommendation, whether it's the EGS or the American Academy, they have highlighted that all these anterior chamber imaging are useful as a supplement to gonioscopy. They cannot replace gonioscopy for a routine evaluation. So gonioscopy is still the gold standard when it comes to evaluation of your angle. Thank you so much.
Despite a patent laser iridotomy, this young hyperopic patient had narrow angles. We see when we indent a marked peripheral roll in the iris that is characteristic of plateau iris. Again, as I push in here, you see this roll in the far periphery, and as I let up on the pressure, that roll goes away. Here with some added fill light, it makes it even easier to see this far peripheral roll on indentation. This is really the hallmark of plateau iris. This patient is mildly hyperopic, about 1.75 diopters. His angle is slightly narrow, but we see the trabecular meshwork nicely. On indentation, as the iris moves back, the peripheral iris is held forward, presumably by the ciliary processes, giving this classic sine wave or peripheral roll that one sees in plateau iris. Again here, indenting, we can see this fullness in the far periphery. If there was not this plateau configuration, the far peripheral iris would push back just like the remainder of the iris. So the iris drapes over the lens and then it should come up to the scleral spur, but in this case it drapes over the lens and comes up over this hump in the periphery, giving one the sense that this patient has plateau iris and an anterior ciliary body. This 76-year-old woman has a history of narrow angles. She's mildly hyperopic and had undergone laser iridotomies. On indentation, you'll notice that when we push, there's a peripheral roll in the far periphery of the iris. This is very characteristic of plateau iris syndrome. Here I am pushing, you can see corneal folds, and you can see a peripheral roll. As I let up on the pressure, the iris comes back forward, the folds go away, and the iris is again flat with a very narrow iridocorneal angle. Again I'm pushing, again you see the far peripheral roll of iris. I find indentation gonioscopy to be tremendously helpful in making the diagnosis of plateau iris syndrome. Again, pushing here, corneal folds are present, and a peripheral roll in the iris. We let up, the iris returns to its normal shape. Here at higher power, again, indenting, and we see the peripheral roll, and we also see the corneal folds.